So next, we're going to have Dr. Syc-Mazurek come up and talk about understanding relapses and importance of disease management in MOGAD. And so half the audience already had an introduction to Dr. Syc-Mazurek. For those that were on the other session, Dr. Syc-Mazurek did her residency in neurology at the Mayo Clinic. Then she did a neuroimmunology fellowship here at Mayo, currently doing a neuro-ophthalmology fellowship. And the plan is for her to stay on as faculty. She has an MD and a PhD, a phenomenal researcher, and has a very strong passion for MOGAD and how it affects the eyes and the treatments. So we're looking forward to hearing this talk.
Thanks so much, Dr. Chen. So I'm going to be talking about relapses today. So first we'll talk about kind of what makes a relapse, and then how do we evaluate and confirm a relapse has occurred. And then we'll finally talk about kind of the implications for what happens once we confirm a relapse and how that kind of changes treatment decisions. So this is when I put into ChatGPT kind of relapses inflammation, relapses in demyelinating disease and inflammation. And this is the picture that ChatGPT generated for me. And the reason why inflammation is so important when it relates to relapses is because relapses indicate a new inflammatory event in MOGAD. And then they can be called different things. So you might hear an exacerbation, an attack, an episode, an event. But kind of for the sake of this talk, we'll kind of refer to them as relapses. And oftentimes there's new symptoms that develop, or always in MOGAD, there's new symptoms or recurrence of symptoms that develop. But new symptoms or recurrence of symptoms don't always mean a relapse, but they always should be investigated. And that's kind of what we'll talk about in more detail. And I think it's important to note that kind of only about half of patients with MOGAD will have a relapse. And kind of this identification of a relapse changes treatment decisions. So both treatment decisions during the acute period, but then also treatment decisions in terms of eligibility for a clinical trial, starting a chronic medication for immunomodulatory therapy, or changing therapy if you're already on a medication. So I was going to talk a little bit about the symptoms that one can have during a relapse, but a lot of these were covered in such excellent talks from before, so I'll kind of be brief about this. But again, a relapse means new inflammation. So the most common relapse in patients with MOGAD is optic neuritis, or inflammation of the optic nerve. And this can present with blurred vision or loss of vision, pain with eye movements, and loss of color vision. And so we often investigate this by looking for that inflammation in the back of the eye, which you can see there, and then also kind of looking for that inflammation on the MRI. Other common relapses in MOGAD are myelitis, and this is inflammation of the spinal cord. So again, these symptoms would be weakness, sensory changes, new bowel or bladder symptoms, or something called Lermite's phenomenon, which is kind of tingling or shock-like sensations down the back with flexion of the neck. And then as we know, MOGAD can also affect the brain, and kind of the area that's affected or the area of where the inflammation is really dictates the symptoms that one might experience. So we know that MOGAD can cause kind of inflammation in one particular area of the brain, or there can be multiple lesions that occur in MOGAD relapses. And it's the location of those lesions or that inflammation that determines the symptoms one might have. So one that we talked about a little bit is this ADEM, or acute disseminated encephalomyelitis. Other symptoms could be kind of affecting, these are more rare, the balance center of the brain, so causing double vision and coordination. Or there can be this encephalitis with headaches and seizures, confusion, encephalopathy. And so how do we evaluate relapses? So I think kind of the first and foremost is calling your health team and calling your neurologist, your neuro-ophthalmologist, and getting evaluated. And so oftentimes in clinic, or always in clinic, we take a careful history. We want to know what the symptoms are. How did they develop? Was this over kind of minutes, hours, days? Have they been there for 4 or 5 months? Kind of that's really important to us. So when did they start? How have they changed over time? And how are these symptoms different from the symptoms that you might have had in the past? So those are kind of the important pieces of information that we want to know from a clinical perspective. The other thing we do in clinic is a careful exam. So how has your exam changed kind of during that evaluation of new symptoms from your evaluation in the past? So are there new findings? Are we seeing changes in the way that the pupil constricts? Are we finding new weakness? Is there a change in your reflexes? And then trying to compare those to how things were during a previous evaluation. As we've talked about today, we also do a lot of imaging. And so kind of using MRI to look for new inflammation in the brain, so enhancing lesions or new lesions that weren't there during a prior MRI can be very helpful. We can also use different structural techniques to look at the structures of the optic nerve and the retina. So something called optical coherence tomography can be used to find subtle swelling in the eye. And then we can do functional testing. So we can, if we're evaluating for optic neuritis, we can check vision, both with high and those low contrast acuity. We can look for visual fields, so kind of what areas of vision might be difficult to see. And then at Mayo Clinic, we've also been doing more functional testing with regards to ambulation. So looking for a gait analysis and seeing if there might be changes. And then there's other things that may cause return or new symptoms as well. And so kind of oftentimes we might be doing blood work or urine in addition to kind of those other tests with the imaging and the clinical investigation. And then there might be, depending on the type of symptoms, there might be other investigations we do, whether it's a brainwave test, an EEG to look for seizures. There might be rare instances where we need to do spinal fluid to look for kind of signs in the spinal fluid, and potentially, depending on the symptoms, other additional testing as well. And so sometimes return of symptoms or new symptoms don't always mean kind of new inflammation. And so the term that's often used as pseudo-relapse, I think there's some kind of troublesome parts that pseudo, I mean, certainly the symptoms aren't pseudo, the symptoms are real and bothersome, but it's important to determine whether those symptoms are a result of a new inflammatory event. And there are certain triggers that we know that can cause new symptoms. And so I think it's important to be aware of those, or return of symptoms. So particularly, I think of them as things that can kind of disrupt the resiliency of the central nervous system, the brain and the spinal cord. And so what can disrupt that resiliency? So infection or illness can often cause worsening or return of symptoms that one might have had during a prior attack. Heat can often kind of exacerbate or make symptoms worse, and we call this Uthoff's phenomenon. Physical exertion or fatigue, again, often because of that kind of generation of heat. And then kind of, I put this as a bucket term of stress, but anything that kind of disrupts that resiliency of the nervous system, so whether it's lack of sleep, again, fatigue, recovering from an illness, can make old symptoms worse or old symptoms return. And so once we've used that kind of clinical testing and the imaging, other tests like blood work, if we find an infection, certainly we would want to treat that. But if we have confirmed a new inflammatory event, then we would start acute relapse treatment. And Dr. Chen's going to be talking about that shortly. There might be an opportunity to participate in a clinical trial if there's a relapse. And then also kind of this would dictate potentially starting an immunomodulatory therapy. So if a person has had then 2 relapses, that often then indicates the need for chronic immunomodulatory therapy. Or if someone's already on medication, it might indicate a failure of that medication and kind of thinking about increasing dosing or changing to a new medication altogether. But if we find that the symptoms aren't because of new inflammation, then there's really not a role for acute relapse treatment or not a role for changing immunotherapy, but we really need to be kind of changing our focus to be thinking about symptomatic therapy. So whether that's physical therapy, occupational therapy, new medications for urinary symptoms or bowel symptoms, new medications for pain or spasticity, treating migraine, those kind of things, really focusing on trying to improve the symptoms that one's having, but not necessarily with immunomodulatory therapy. And it's that careful balance, trying to make certain that we're doing a careful investigation to look for that new inflammation, but then also not kind of exposing people unnecessarily to medications that have side effects if they don't necessarily need their medications changed. And so it can be really challenging to determine the difference between a relapse or return of symptoms with a pseudo-relapse, but there's kind of some things that can be helpful in determining that distinction. So one is timing. So often with a relapse, symptoms might come on over hours or days. So these aren't symptoms that would come on over 4 to 5 months and gradually worsen. Typically, it's kind of that more days to a week or two. And then symptoms persist, so they would last for 24 hours. So these aren't symptoms that worsen over a period of, or come for 5 or 10 minutes and then go away and then come back. So those transient symptoms are likely more suggestive of a pseudo-relapse, but still may require investigation. And then again, the type of symptoms can sometimes be helpful determining the difference between a new inflammatory event and not. So oftentimes with a relapse, it can be return of old symptoms, but it can also be new symptoms. And a pseudo-relapse, oftentimes it's symptoms that were previously there from a prior attack or worsening of chronic symptoms. But again, it's really, really challenging to tease out the difference of these two just on the history. And so that's why all those other investigations can be really helpful. And so why it's so important to kind of call your doctor to investigate further if symptoms have worsened or you have new symptoms. So in summary, relapses happen in only about 50% of patients with MOGAD. Relapses happen because of new inflammation, and those symptoms are based on where that inflammation occurs. Clinical investigation and testing is really crucial and kind of can help determine the difference between a relapse and a pseudo-relapse. And it's important because it changes treatment. So it changes acute treatment, it may change chronic treatment. And again, treatment goal is always to improve current symptoms. And then particularly in the case of an identified relapse, the other goals are to prevent future relapses. And happy to take any questions. Thank you.
Andrea Mitchell, MOG Project. So how do you get your neurologist to truly listen to you? I'm serious. I'm fed up.
I'm sorry that things have been difficult. I think kind of as a developing neurologist who's really been kind of privileged to train here at the Mayo Clinic, I think it's really important that we as kind of medical professionals develop partnerships with our patients. You know your symptoms the best, and I think it's really important to listen. And so I think finding that right partnership is critical, and I think that's the thing that we strive for here.
The problem is we don't have many MOG doctors where I live.
Yeah, and access can certainly be challenging, and I think that's one of the wonderful things of the MOG project and the research that is going on is to try to really spread information about the disease, and so that we can not only kind of help our patients here at Mayo, but also beyond our walls.
Thank you for that. We have another question that came in from the community. One of them, there's actually a few. One of them's for Dr. Tillema, which we probably could get to in a minute. But they ask if someone has a mild versus severe first attack, does that help predict the likelihood of relapse risk? Also, if a child is older, like say 15 to 18 years old, would that be considered more of an adult case since puberty has already occurred? And so this relates to the question for Dr. Tillema, I think, about puberty.
Those are both great questions. Certainly, we know that in children with ADEM, and I'll defer this more to Dr. Tillema, who knows more about this than I do, but we do know that in patients that present with ADEM, that they're less likely to have a relapse later. With regards to kind of the severity of illness, I think it's challenging to predict. I think we still don't know enough about who is going to go on to develop a relapse and where that relapse might occur. I mean, certainly kind of we know that optic neuritis is the most common cause of relapses. And so we also know that patients who present with an optic neuritis are more likely to go on to have a relapse than a child with ADEM. But as far as parsing out kind of who's going to go on to develop a relapse, we don't have biomarkers that can definitely help us answer that right now. With regards to the pediatric and puberty, I think we think of them more as adults, but I would defer to Dr. Tillema for more details on that.
Did you want to answer that? And then...
Yeah, I can. So most 15 to 18-year-olds think they're adults, but the course is not necessarily different, or the treatment is not necessarily different. So it's most of the time I experience that the very young children that they behave much differently than the adults. And for MOGAD in particular, the hormonal and pubertal role is not as important as it is for multiple sclerosis, for example. So it always depends a little bit, but most of the time our teenagers, we treat them similar to adults for the majority of our conditions. And sometimes they tend to do a little bit better, sometimes they do worse. It's not really anything that can predict based on the age in that setting.
Well, since you have the microphone, I guess I could sort of ask the second half of another person's question that asked about hitting puberty, and it tends to impact relapsing MOGAD. But the question is, do they need to change treatment during or after puberty, or does that presentation sometimes shift, say, from an we already kind of know.
Yeah, no, the short answer is no. So we don't look at age, we don't look at sex or hormonal status for the treatment. We look whether they responded yes or no. And if you are treated well, then we tend to not change it. And if you're treated for a long enough period, again, in particular in the pediatric cases, the relapse rates seem to be lower. But we don't have enough long-term data out there to say anything else with certainty. So it really is therapy effectiveness that drives the treatment.
Okay. And finally, I'll ask one more, and then I'll leave it off to the audience. And this is for you. And how strong is the data supporting the 50% monophasic figure? Could this figure be underestimated due to challenges tracking patients that move locations or hospital systems? Do you know?
Yeah, it's a great question. I mean, I'm certain that there are relapses that we do miss just because of access to care or access to detailed clinical testing. At the same time, kind of we do have kind of a large number of patients that we follow here, and it seems that number is probably close to what we're seeing in our patient cohort, but again, impossible to know for certain, and kind of why it's so important that we have these large epidemiology studies.
I might make a quick comment just on that. The other thing is that people who have just one episode, they tend not to return to see neurologists, so sometimes they're under-captured. So some studies that have followed people ongoing. There's one study in Oxford, and they followed everybody newly diagnosed and followed them forward, and they found about 36% had relapsed by 8 years. So it can be both ways. We can both miss it, or we can overrepresent it because those people are coming back to see us, and some of the people with the milder cases are not, and then we don't capture those too.
Hi there. I was wondering if there's genetic research on genetics with both new cases and relapsing cases ongoing, and what people have found, because it's such a hot topic in many diseases. Thanks.
Yeah, it's a good question. So in MOGAD, we don't have a specific gene that we've recognized, or that's recognized to cause the disease. Certainly, we still don't know what causes MOGAD. And so there may be some genetic predilection in some people where it's the specific genetic makeup that might predispose to MOGAD. We know that happens in autoimmune disease. But as far as a specific kind of clear association of a gene and the disease, that hasn't been found. There's work on genetics. I'm not familiar with the very specifics of that research, though. I'll defer to Dr. Flanagan.
There have been some studies on the genetics, and it maybe of about 200 patients or so, and they didn't find any genetic association. But with some of those genetic associations where there's not a clear gene causing the disease, it takes very large numbers. So many of us, as part of the research, we collect DNA, and we're working with other groups around the world to try and kind of team up and work together as a group to try and get more information to see. So probably something will come down the line where we might get a better sense, but you need very large numbers, so we're not there yet. Yes, AI, yep. But hopefully it doesn't replace all of us. Let's go.
Hi, I'm wondering for patients that have been diagnosed with MOGAD, if you're seeing an uptick in any other autoimmune disease that would be neurological.
So certainly we know that kind of autoimmune diseases can cluster, and so patients with a history of autoimmune diseases are more likely to potentially have another autoimmune disease in general, and that doesn't necessarily refer to just the neurologic phenotype. I think one of the things that we do think about are kind of MOGAD and another condition called NMDA, so kind of an autoimmune encephalitis, and we do know that in a small proportion of patients there's overlap there.
Have you seen any connection or an uptick in relapses since the onset of COVID?
That's a good question. So it's something we're actively investigating now, not particularly with COVID, but this idea that kind of, as we talked about a little bit, that we still don't know what causes MOGAD, but certainly in some patients it does seem that an infection, there might be an infectious trigger. Exactly how that works, we don't have the research to support that now, but there have been patients that have had COVID and then develop symptoms of MOGAD. I don't think there's data to support right now that it's specific to COVID, but more so that there's some sort of viral or infectious trigger that triggers the immune system that in some patients causes a development of MOGAD. Right. Okay. Thank you.
Great.